Preterm care, education for mothers. A preterm birth refers to the birth of a baby before 37 completed weeks of pregnancy, less than 259 days. The terms preterm and premature are often used interchangeably to refer to the same condition. Preterm birth can increase the risk of various health problems for the baby, such as respiratory distress syndrome, infection, and long-term developmental delays. Maternal perceptions of preterm. Initial anxiety and stress. The early birth of a preterm infant can be unexpected and stressful for mothers who may feel unprepared. The NICU environment can be overwhelming to the mothers. Shifting perceptions. Involving mothers in preterm care. Mothers often initially feel like outsiders in an unfamiliar world. However, through interactions with the healthcare team and their growing caregiving abilities, they gradually develop positive perceptions and competence to take care of the preterm babies. Positive bond development. While preterm infants may be less responsive than term infants, mothers can still develop strong bonds and form positive attachments. Importance of support. Access to adequate support, including psychological support and interaction with the healthcare team, can help mothers cope with the challenges and develop more positive perceptions of their preterm babies. Negative perceptions and challenges. Some mothers may experience difficulties in adapting to parenting, especially if they are also experiencing other health or marital problems. Mothers of preterm infants may also be at risk of postpartum depression. Impact of maternal mental health. Maternal mental health plays a crucial role in the development of positive or negative perceptions of the preterm infant. Depressed mothers may have difficulty with parenting and interpreting their baby's behavior. Long-term implications. Early maternal perceptions and interaction patterns can have long-term implications for the child's development. Need for NICU. Preterm babies require care in a neonatal intensive care unit known as the NICU due to their undeveloped organ systems and inability to fully regulate their body temperature, breathing, and feeding. The NICU provides a specialized, controlled environment to support these babies until they mature enough to survive independently. Here's why NICU care is crucial for preterm babies. Immaturity of organ systems. Preterm babies are born before their organs are fully developed, making it difficult for them to regulate body temperature, breathing, digestion of food, and handling stress. Respiratory distress. Many preterm babies experience breathing problems due to underdeveloped lungs, which can be managed in the NICU with respiratory support like mechanical ventilation. Feeding challenges. Preterm babies may have difficulty coordinating sucking, swallowing, and breathing, requiring specialized feeding methods and nutritional support in the NICU. Infections. NICUs are equipped to prevent and treat infections that preterm babies are at high risk due to their immature immune systems. Other medical needs. NICUs also provide care for other preterm complications like jaundice, anemia, and intraventricular hemorrhage. In summary, NICU care is essential for preterm babies to provide a controlled environment. Incubators and specialized equipment help maintain a stable temperature and humidity crucial for preterm babies. Offer respiratory support. Babies can receive breathing assistance, including ventilation, to manage respiratory distress. provide feeding support. NICU staff help preterm babies learn to eat and provide the necessary nutrients. Monitor vital signs. Continuous monitoring of heart rate, breathing, and blood pressure helps track the baby's progress. Treat potential complications. NICUs are equipped with experienced healthcare professionals and equipment to handle various health issues that can arise in preterm babies. Information to mothers while entering the NICU. The following information is given to mothers of preterm babies, which will help them in handling the baby in the NICU and enable them to take part in the NICU care of the babies. Any doubts will be cleared by the doctors or nurses after watching the video whenever the need arises. Any questions regarding other issues like bonding, anxiety, stress can also be communicated to any healthcare workers if the mother feels that she is required additional help or support. Hand washing. The WHO recommends a 7-step process for proper hand washing. First, wet hands with clean running water, warm or cold. Second, apply enough soap to cover all surfaces of your hands. 3. Rub hands together vigorously for at least 20 seconds, ensuring you clean all surfaces, including the back of hands, between fingers, and under nails. 4. Rinse hands thoroughly under clean running water. 5. Dry hands with a clean towel or air dry. 6. Use a clean towel to turn off the faucet. 7. Your hands are now clean. Vitals monitoring. In the NICU, mothers can actively participate in vital sign monitoring. This is done by observing the monitors which displays the baby's vitals like temperature, heart rate, oxygen saturation, and respiratory rate. This helps to keep a close watch on the baby's well-being while the mother is in the NICU, and she can inform the staff if there is any abnormality. By engaging mothers in this process, the NICU staff can foster a collaborative approach to care, reduce maternal stress, and potentially improve infant outcomes. Temperature maintenance. Newborns, if left wet and naked, lose up to 2 to 4 degrees Celsius within 10 to 20 minutes. Large surface area, head big in size compared to its body, and less subcutaneous fat adds to further decrease in temperature. There is an increased risk of death, especially in LBW and preterm babies if hypothermia continues. It decreases ability to suckle at the breast, leading to poor feeding and weakness, and more prone to increased susceptibility to infections. So baby should be kept dry and well covered at all times. Take axillary temperature using a digital thermometer. The digital thermometer needs to be switched on for the recording of temperature. Temperature is recorded by placing the tip of the digital thermometer in the roof of dry axilla parallel to the trunk. Newborn's arm is held close to the body to keep the thermometer in place. The temperature is read when the thermometer beeps. Normal axillary temperature is 36.5 to 37.5 degrees Celsius. The recording should be noted after the beep. There should be no addition or subtraction to the displayed temperature. In hypothermia, the temperature is below 36.5 degrees Celsius. The common signs and symptoms in a hypothermic newborn are lethargy, irritability, poor feeding, and breathing difficulty. Tactile assessment of temperature. Temperature of a baby can be assessed by reasonable precision by human touch, which can be enhanced by practice. Abdominal temperature is representative of the core temperature and it is reliable in the diagnosis of hypothermia. The warm and pink feet of the newborn indicate that the newborn is in thermal comfort, but when feet are cold and abdomen is warm, it indicates that the newborn is in cold stress. In hypothermia, both feet and abdomen are cold to touch. In a newborn being nursed under a radiant warmer, temperature is usually recorded by a thermistor probe. The thermistor probe is attached to the skin over upper right side of the abdomen. The thermistor senses the skin temperature and displays it on the panel. Feeding practices. Low birth weight infants need optimal nutrition during the neonatal period for proper growth and development. Appropriate feeding of low birth weight and very low birth weight infants improve their chances of survival and is important for their optimum growth and development. Breast milk is the ideal food for all infants, including those who are low birth weight. WHO recommends that all low birth weight infants, irrespective of their gestation, be fed breast milk. The goal is to enable every low birth weight infant to receive feeding directly and exclusively from her/his mother's breast at the earliest. However, many preterm infants have feeding difficulties initially because of inability to coordinate suck, swallow, and breathing, immature and sluggish gut, systemic illness, poor attachment and sucking effort on the breast, poor swallowing, easy tiredness, vomiting, regurgitation, or abdominal distension. Lower the birth rate, greater is the likelihood of feeding difficulties. These infants may not be stable enough to tolerate enteral feeds and are therefore provided intravenous fluids till such time that enteral feeding can be established optimally. Direct feeding from the mother's breast may not be possible or may not be enough to fulfill the needs in many others, and in this situation, feeding may need to be provided by alternative feeding methods such as feeding tube, spoon, paladi, or cup. Preterm infants who are able to breastfeed should be put to the breast as soon as possible after birth when they are clinically stable and should be exclusively breastfed until 6 months of age. Preterm infants who are unable to take directly from the breast may be fed by a orogastric tube, feeding cup, paladi, or spoon. Mother's milk is best for low birth weight infants of all gestational ages. Breast milk and especially colostrum, the thick yellowish milk which is produced in small quantities during the first few days after delivery, best assures the survival and well-being of low birth weight infants. Breast milk is especially adapted to the nutritional needs of low birth weight infants. For example, the breast milk of a mother who delivers a preterm low birth weight infant contains extra protein that is necessary for the normal growth of such an infant. Breast milk provides many anti-infective factors, a vital component of the immune system of a newborn infant, and growth factors which help gut development. There is strong and consistent evidence that feeding mother's milk to low birth weight infants of any gestation is associated with lower incidence of infections and better long-term outcomes. Every effort should be made to provide direct breast milk to stable preterm infants. This would require initiating and providing kangaroo mother care (KMC), initiating breastfeeding as soon as the baby is stable, offering breastfeeding frequently, approximately every 2 hours and on demand if required, ensuring continued frequent feeding whenever possible, ensuring proper positioning and attachment, monitoring the baby closely for and complications like abdominal distension, vomiting, feed intolerance, etc. Managing breast or nipple problems such as retracted or cracked nipple and breast engorgement. Milk bank. Expressed donor milk from other lactating women. At times, breast milk output in the mother of low birth weight infants may not be sufficient, especially in the first few days. Given the importance of breast milk to the infant, the use of breast milk obtained from other lactating women or donor milk is recommended. Ideally, this should be organized in places where breast milk bank is established. Proper breast milk bank ensures that donated milk is safe and healthy. Formula milk. When not enough breast milk is available to meet the needs of a low birth weight infant, formula milk may be given with proper preparation and hygiene only when prescribed by the healthcare professionals. For infants below 1500 grams of birth weight, a special preterm formula is preferred. The formula milk should be given under the guidance of a pediatrician. Methods of feeding when direct breastfeeding is not possible. Feeding tube, spoon, paladi, or cup are the alternative methods of feeding when direct breastfeeding is not possible. Paladi is a shallow steel bowl with a long beak. Mother-infant interaction. In the NICU, mother-infant interaction, particularly with preterm infants, is crucial for development and bonding. Early interactions like skin-to-skin contact and parent participation in care can positively impact a baby's well-being and strengthen the parent-child relationship. The following are the main methods which, with the mother-infant interaction, can be established: KMC or skin-to-skin contact and eye-to-eye contact. Importance of early interaction. First is the developmental benefits. Positive interactions promote the baby's socio-economical and behavioral development, especially for vulnerable preterm infants. Second, attachment. Early interaction is vital for forming secure attachment, which is linked to better social and emotional competence, resilience, and mental health later in life. Third, parental well-being. Parent participation in the NICU can boost their sense of usefulness. And fourth, improved infant outcomes. Parents can help their baby cope with NICU stressors, provide appropriate sensory stimulation, and encourage interaction. How to establish early interaction? First, parent education and support. Training mothers on observing and interpreting their baby's cues can improve their ability to interact effectively. Second, parent participation in care. Encouraging mothers to participate in basic care like feeding and holding can enhance their sense of involvement and strengthen their bond. Third, addressing parental stress. Providing support and resources for mothers to cope with the stress of the NICU experience is essential. Fostering positive mother-infant interaction in the NICU is crucial for the baby's well-being and development, as well as the parent's psychological adjustment. By addressing the challenges and promoting positive interactions, NICU staff can help mothers and families form a strong and nurturing bond during this challenging time. KMC, Kangaroo mother care is a low resource, evidence based, high impact intervention and standardized care for preterm infants, which, like breastfeeding, should be part of the routine. It can prevent up to half of all the deaths in infants weighing less than 2000 grams. Kangaroo mother care has following components: 1. Skin to skin contact, 2. Exclusive breastfeeding. Kangaroo Mother Care (KMC) is a simple method of care for preterm infants that includes early and prolonged skin to skin contact with the mother or a substitute caregiver and exclusive and frequent breastfeeding. This natural form of care stabilizes body temperature, promotes breastfeeding, prevents infection and other morbidities. This also leads to early discharge, better neurodevelopment, and encourages bonding between mother and infant. KMC is initiated in the hospital and continued at home until the infant needs it, and for optimum care and a regular follow up must be ensured. Eye to eye contact between parents and preterm infants is a crucial aspect of development and bonding, but can be impacted by factors unique to the NICU environment. Very young preterm babies may only occasionally make eye contact, while older preterm babies gradually engage in more frequent and longer periods of alertness and eye contact. In the NICU, mothers may experience unique circumstances, including minimal handling, physical barriers like incubators, and the chaotic environment, which can affect the quality of parent infant interaction. Challenges: Developmental considerations. Preterm infants, especially those born very early, may have different visual and social development patterns compared to full term babies. They may have less developed visual attention skills and may avert their gaze more often during social interactions. NICU environment. The NICU setting, with its medical interventions, equipment, and the potential for physical separation between mother and infant, can create unique challenges for parent infant interaction. Minimal handling and the use of incubators can limit early interactions and make it harder for parents to engage in face to face communication. Supporting eye contact. Mothers can support eye contact and bonding by being mindful of the infant's cues and alert periods, making eye contact during interactions such as while feeding or holding the baby, engaging in gentle touch and skin to skin contact, providing a calm and supportive environment for the infant and themselves, seeking support from NICU staff and other resources to navigate the challenges of parenting a preterm infant. Multivitamins and supplements. Micronutrient supplementation is essential for the proper growth and development of the preterm babies. The following supplements are recommended by the WHO. Vitamin D, 400 to 1000 international units per day, usually in the form of multivitamin drops containing calcium and phosphorus for 6 months, starting as soon as possible. Iron till 1 year, starting at 2 weeks of age. Calcium and phosphorus till 40 weeks of corrected gestational age in infants and below 32 weeks of gestation. Weight monitoring. All the infants should be weighed after stabilization and birth weight recorded regularly. The mother or caregiver can help in regular recording of weight. A single-use paper towel or a sterile cloth towel should be placed on the weighing scale beneath the infant. The baby's weight must be documented every day in the morning at the same time with minimal clothing. The weighing scale must be periodically calibrated routinely for accurate weight measurements. Infection prevention. Care of umbilical stump. The cord must be left open without any dressing. Check for redness and discharge. Do not apply any medication on the cord. The cord usually falls after 4 to 10 days. Skin care and bathing. It is preferable to bathe the baby when cord dries off. Healthy preterm babies can be given a bath when they are clinically stable and gaining adequate weight as advised by the pediatrician. But until then, daily sponging is recommended in the NICU. Special precautions must be taken during sponging or bathing to prevent hypothermia. During the winter months, instead of bathing, the baby can be sponged daily to avoid unnecessary exposure and risk of hypothermia. To keep the small baby clean, advise mother to give a light oil massage followed by warm water sponging to clean the oil, but making sure that the room is warm and the baby is not left uncovered for more than 10 minutes. The mother or caregiver should not pour oil into any orifice like the nose or ears at any time. Eye care. Routine application of antiseptic or ointment for prevention of eye infections is not recommended. Some neonates may develop persistent epiphora or watering due to blockage of the nasolacrimal duct by epithelial debris. The mother or caregiver must massage the nasolacrimal duct area by massaging the either side of the nose adjacent to the medial canthus 5 to 8 times daily, each time before she feeds the baby. The use of kajal must be avoided as it may transfect infections, cause injury, or even cause lead poisoning. Oral care. Oral cleaning in the NICU is crucial for preventing infections and promoting overall well-being, especially in vulnerable infants. It involves using a sterile swab or oral applicator to gently remove debris and bacteria from the mouth, potentially using colostrum, breast milk, or sterile water. The goal is to minimize oral complications and the risk of ventilator-associated pneumonia. This practice helps support immune function, stimulate development, and can even reduce the length of hospital stay. Benefits of oral care. First one, improved sensory experience. Oral care can stimulate the infant's senses of touch and taste. Second, reduce risk of infections. Breast milk and colostrum can help protect against infections in the mouth and upper respiratory tract. Third, improved parental confidence. Parents may feel more confident in their ability to take care of their infant. 4. Positive oral experiences. Providing positive oral experiences such as introducing different textures and flavors can help development a positive association with feeding. Warning signs. All danger signs in the baby should be explained to the mother or caregiver before discharge, and she should be advised to bring the baby to the facility if any of the following danger signs are observed. Baby cold or hot to touch, inability or difficulty in feeding, difficulty in breathing or fast breathing, abnormal movements, less movement, or appearance of jaundice within 24 hours of age by seeing the yellow staining of palms or soles. The caregivers or family members may also be counseled to seek care in case of persistent vomiting, excessive crying, drooling of saliva, or choking during feeding, bleeding from any side, superficial infections such as conjunctivitis, pustules, umbilical sepsis, which is the redness at the base of the stump and discharge, oral thrush, etc. Mother-infant bonding. Maternal-infant bonding in premature babies can be challenging due to the circumstances of their birth and the need for the NICU. While the process may be delayed or disrupted, research indicates that healthy management and bonding can be established and be of higher quality in some cases compared to full-term infants. Challenges. First, premature birth and NICU. The stress of preterm birth and the subsequent hospitalization can interrupt the normal bonding process. Mothers may experience feelings of helplessness, guilt, and anxiety. 2. Limited physical contact. NICU environments often restrict physical contact due to medical needs and the need to monitor the baby's health. 3. Emotional strain. Mothers of preterm babies may experience high levels of stress and anxiety, which can impact their ability to bond with their infant. 4. Delayed bonding. The process of bonding may be delayed or disrupted, with some studies suggesting that differences in maternal-infant interactions may be most noticeable during the first 6 months of life. Factors that support bonding. 1. Skin-to-skin contact or kangaroo care. This practice, where the baby is held against the mother's chest, has been shown to be beneficial for both the baby and the mother, promoting bonding and improving breastfeeding. 2. Maternal presence and voice. Maternal presence and voice have a positive effect on premature babies in the NICU and have a positive effect on mother-infant bonding, according to many studies. 3. Encouraging participation in care. Allowing mothers to participate in their baby's care, such as feeding or bathing, can foster a care of connection and competence. 4. Breastfeeding. Breastfeeding, even if only expressing, can contribute to bonding and has numerous health benefits for both the mother and the baby. 5. Social support. Support from family, friends, and healthcare professionals can help mothers cope with the challenges of raising a preterm baby and building a stronger bond with their child. 6. Self-support. Mothers can also foster bonding through self-care practices like seeking counseling or therapy if needed. Conclusion. Early maternal-infant bond is highly important, especially for the growth and development of premature babies. Mothers who are educated about the care of preterm babies and provided the support will be able to confidently take care of such babies. Hence, it is important to educate them and clear any doubt in order to establish early maternal-infant bonding.